Hello and welcome to the show. We're tackling a topic today that many women who have faced breast cancer are told not to even consider: hormone replacement therapy. So our guest today is a true trailblazer in this field. Dr. Alison MacBeth is a breast specialty doctor and a British Menopause Society accredited menopause specialist. After seeing countless patients suffer from debilitating menopause symptoms after breast cancer treatment, she began a passionate mission to ensure that all women, regardless of their medical history, have access to high quality, evidence-based menopause care. So today we're going to dive deep into the big questions that women have about HRT and really what it means to have an informed choice. And it's a conversation that you really don't want to miss. Dr. MacBeth, welcome to the show.
Thank you so much for having me.
Oh, it's really great. Thank you so much for your time. You're based in Scotland, right?
In Scotland, yep.
Okay, fantastic. Dr. MacBeth, you specialize in a topic that's often filled with fear, misinformation for women who have had breast cancer or cancer. Could you take us back to the moment in your career? Perhaps it was a specific patient, a personal experience that really ignited this passion in you. What was the moment where you knew you had to just start this work and challenge the status quo?
Well, I actually started life as a family physician, qualified 99, and then I actually went straight out to Canada. I've worked in Canada for 5 years. Started a menopause clinic in BC. I was in northern BC. So I've always been really passionate about menopause care and women's health. And then when I came back to the UK, I started working as a family physician in the breast cancer unit that was near me.
Okay.
And I think when you're a family physician, you're working holistically compared to breast surgeons who are purely just focused on the boobs and trying to fix what is trying to kill you. But I would sit there every day and I would see these women really suffering from their cancer treatments and from the endocrine treatments that we're giving them. We're forcing them into menopause, or we're making them stop their HRT at diagnosis. And I could just really see the struggle. And the problem was that everyone I was working with, I mean, fabulous healthcare professionals, but they were just so focused on the breast that nobody was really looking at the bigger picture. So these women were just kind of left in this no man's land of nobody knew what to do with their side effects and their menopause symptoms. And so they were just kind of being told, look, you should just be happy you're alive, just get on with it, suck it up, tolerate that treatment. And so many women were just stopping their treatment and not telling us. And I could see that, and I would kind of build up this relationship with the women. So eventually they would tell me, and I'm thinking there must be a better way. And this was several years ago, and nobody was really talking about menopause after cancer at that point. And certainly nobody was talking about HRT after cancer at that point. We still had the hangover effect from the WHI trials, and in breast surgery, estrogen is seen as the root of all evil. So it was hard. It was really heartbreaking seeing women just suffer every single day.
Yeah. It's tough. I'm so glad we're having this conversation today. So many women who've had breast cancer are told that HRT is off limits. I think the burning question is, are we dealing specifically with you today about breast cancer and why? The listeners might be thinking, oh, well, I know somebody who has cancer, but are we talking specifically about breast cancer because of your experience? Or does this extend into other cancers as well?
So I'm a breast cancer specialist, so I'm going to be mainly focusing on breast cancer today. And we can touch on other cancers if you want. I think women are often lumped into this, oh, you've got cancer, you can never have HRT. But actually, for a lot of cancers, HRT is advantageous. A lot of hematological, so blood cancers, colon cancer, some skin cancers, it's actually advantageous to have it, and a lot of other cancers it's completely neutral, things like kidney cancer, hormone receptor positive breast cancer, there's it's thought of as a contraindication, the same as high risk womb cancers, some ovarian cancers but not all of them, lung cancer, and some brain cancers, it's contraindicated. So essentially not all cancer is the same, but some HRT is great, some is neutral, some is seen as bad.
Okay, good. So I think that kind of clarifies that a little bit. And then when we speak about it's off limits for breast cancer, maybe what is the traditional thinking behind this? Like, what is the core concern that using a hormone after a cancer diagnosis, what are people so worried about? What is the big question?
So shall I take you back to when they decided that they needed to answer this question? So essentially it was the 1990s. They had a lot of kind of observational trials at that point that, and it actually
Yeah.
seemed to be that HRT was possibly advantageous. We were using a lot of HRT in the 1990s. I was running my menopause clinics. We were prescribing it a lot. This was well before the WHI trial that terrified everybody. So in the 1990s, there was all sorts of calls for trials to be done. And then they eventually started trials in the early 2000s. And the two big ones are HABITS and Stockholm. So HABITS is HRT after breast cancer, is it safe? And Stockholm was also a trial in breast cancer patients. And they were both done in Sweden. I'm not quite sure what was happening in Sweden at the time, but anyway, they were both done in Sweden. And it was to answer the question, is giving HRT safe? Now, HABITS was supposed to run for 5 years and have 1,300 women in it. It only ran for 2 years and was stopped early because of concerns with increased risk of recurrence. So it only had 434 women in it. So it was what we call underpowered, not enough women. And at the time they stopped it in December 2003, there was a difference of 26 women recurred in the HRT arm versus 7 in the non-HRT arm. So those were the numbers when they decided to stop it. And there was a lot of problems with the HABITS trial though. So there was no imaging criteria to enter the trial. So there was no mammograms done. And so with the recurrences they saw, they might have been there all along. They were also, it was done on what we call intention to treat, which meant that, half the women were supposed to take HRT and half the women weren't supposed to take HRT. But there was several women in the HRT arm that didn't. I think it was 11, and there was 43 in the non-HRT arm that actually did take it. So that really, because the numbers were so small, that really threw the bias, threw the numbers off. And they were using different types of HRT, although the most common one then was your conjugated estrogen. However, there was oral estradiol used as well. So there was different types of HRT and high doses of synthetic progestogen. So they stopped it December 2003, and then they looked at follow-up after 4 years, and they could see that there was a difference of 22 women. So 39 compared to 17 that had local recurrence. So local recurrence means recurrence in the same breast or recurrence in the other breast, the contralateral breast. There was no increased risk of distant metastasis, so the cancer spreading to distant parts of the body, and no increased risk of death. And although nobody wants a recurrence whatsoever, a good surgeon can deal with a recurrence, but yes, of course, it can lead to extra treatment, extra chemotherapy, endocrine, radiotherapy. So nobody wants a recurrence, but there was no increased risk of dying with the HRT. And then the other trial was Stockholm. So that was the other Swedish trial. That stopped early purely because HABITS had shown an increased risk of recurrence. And long-term follow-up of Stockholm didn't show any increased risk of recurrence or new breast cancer events or increased risk of dying. It did show a slight increased risk of new cancers on the other side, but no increased risk of overall changes to your breast cancer risk or risk of dying or mortality. So unfortunately, all the guidelines are based on the HABITS data, and it's because medical professionals are very risk adverse, and that's completely understandable. We're none of us want to do any harm, and so the guidelines are based on that one study, and that one study is over 20 years old, and breast cancer treatment and HRT has moved on significantly since then.
Yeah, unbelievable. So a patient comes to you, she's been diagnosed with breast cancer. What is your advice to her right now? She wants to take HRT. She understands the benefits of it. Does she wait until she's finished chemotherapy? What is the protocol here?
So I think it's really important to say that not all breast cancers are the same.
Okay, let's talk about that.
Yeah, so I'm a dog person, so I often use dogs as my analogy. So, I'll say to women, like, some breast cancers are chihuahuas and some are Rottweilers.
Yes,
So not all breast cancers are the same. And they also, we're talking about hormone receptor positive and hormone receptor negative. And when we talk about ER positive and PR positive, these are receptors on the breast cancer cell that respond either to estrogen or progesterone. It doesn't mean estrogen or progesterone has caused the cancer. It just means that the breast cancer has got receptors that respond to estrogen or progesterone or both.
Right.
And then there's another receptor we look at called HER2, and that's a protein. And again, we're checking to see if the breast cancer responds to that receptor. So that's why, some women have a hormone receptor positive, and about 80% of breast cancers are ER positive. That's the most common type with the best prognosis. So you'll have women talk about ER positive or hormone receptor positive, HER2 negative, and that's the most common type, or you might have ER positive, HER2 positive, so triple positive, or you might have triple negative, and that's ER negative, PR negative, HER2 negative. So you can get a whole variation, and they all carry different risks with regards to receptor status, but also it all depends on your age at diagnosis, your hormonal status, the size of the tumour, how aggressive it is. So grading looks at how aggressive it is. Staging looks at how big it is and how far it's spread. It's everybody's so individual, and that's why breast cancer outcomes are so much better these days. We get 90 to 95% cure rate of early breast cancer, and it's because of our treatments is so individualized, because all breast cancer is the same. So if I see a woman in so I run a specialised menopause clinic after breast cancer. My breast cancer unit is the only one in Scotland. I think the biggest thing we can give these women is time. And so my appointments are an hour, and I'll sit down with her. And what I usually say is, look, if you've got hormone receptor positive breast cancer, then it's important to try and get through your treatment first. So we can consider HRT, but we would much prefer you to be finished your treatment. So finished your surgery, your radiotherapy, your chemotherapy, and your endocrine treatment, whether that be 5 years or 7 years or even 10 years. We prefer women to have completed their treatment. Now, not every woman will get that far. 60% of women will only be still taking their endocrine treatment, so their tamoxifen or aromatase inhibitor, after 5 years. And they're generally stopped because of side effects. So we know compliance is really affected due to side effects. So not all women will get to that 5-year point. And so, I do have women who come and see me after 2-3 years and say, look, I just can't bear this anymore. I need to start HRT. And all you can do is have an honest conversation and say, look, there are very few trials and they're old. So as I say, the two main ones were HABITS and Stockholm. There was another one called Liberate that did show an increased risk of recurrence, but that was using an old-fashioned HRT called Tibolone. We've got that in the UK, and I believe you've got that in Canada as well. It's not available in the States though, but that's a totally different type of HRT. And that did show an increased risk of recurrence, but it did show that actually women felt so much better on it. Their menopause symptoms were great, and it reduced their risk of hip fracture. So there was some positives to that as well. And we're never going to get those gold standard studies anymore, because it's not ethical to take these women that have been diagnosed with breast cancer and say, okay, you're having HRT right now and you're not. And we need huge numbers, and by the time we got the numbers, HRT and breast cancer treatment will have moved on. So we're not going to get that. So the only thing that we've got at the moment is actually to kind of look back retrospectively at women who were diagnosed with breast cancer, who were given HRT, and we're trying to keep a cancer so basically an HRT registry, and so we can look back and see, okay, is it an issue or not? With today's modern HRT and today's breast cancer treatments, there's no strong signals that it's unsafe. However, we can never say, it's 100% safe. We just don't know. And you have to be honest and say, look, we just don't know. The concern is that if you've got a kind of your breast cancer's in remission, and so you've got you might have some sleeping dormant cancer cells that you don't know about. And then if you give HRT, you can wake them up. So that's the concern. We don't have hard and fast evidence for it, but that's the concern.
Yeah. I was just going to ask that question, and that's so true. I think the big thing is when we take these things, the big concern is, oh my gosh, we're going to wake these cells up and we're going to stimulate this whole thing and recurrence, etc., etc. Doctor, can we talk about the different types of ways of taking the HRT specific to breast cancers? Are you recommending the patches and the gels? So transdermal versus oral, what is your recommendation for patients, or is it very individualized?
So if we get to the point that and it's really important to have a shared decision making, where this isn't the 60s, we're not paternalistic, or we shouldn't be paternalistic anymore. So we should be having these shared decision makings with the patient. So if we've agreed to try HRT, then I think there is a huge misconception that transdermal is safer than oral with regards to cancer risk. So with regards to blood clot risk through the skin is safer than oral. But actually for breast cancer, there's no difference between through the skin or oral. And again, there's this misconception that it's body identical estradiol is safer. But actually, all the evidence we have is it's actually the conjugated estrogens. We've got so much data and data from the WHI trial. And although that was the bane of women's health, but it was reported badly, but we've got good data from it. Okay. And so we can see that with the conjugated estrogen, which is the Premarin and the pregnant horse urine, if you've got estrogen alone, you've either got no increased breast risk or probably 23% lower risk of breast cancer and about 40% lower risk of dying of breast cancer. So this is women that haven't had a breast cancer.
Wow.
And in the HABITS trial for women with breast cancer, it did show recurrence, but actually not the women that were given conjugated estrogen alone. So women who didn't have a womb could be given estrogen alone. So the ones that had conjugated estrogen alone, they didn't show an increased risk of recurrence. And with the conjugated estrogen, I like to say to women, it's like a bag of sweeties, and they're all different sweeties, and it's the same in the conjugated estrogen. It's all different types of estrogen, and they all work in a different way, and some are breast protective, some are breast neutral, and some may be worse for the breast. Whereas your body identical estradiol, which we still use and I still do use, is just basically one type of estrogen, estradiol, E2. So there is HRT that's not available in the UK, but it is available in Canada, called Duaviv. And they actually just presented a study at ASCO this summer that was really exciting. And it was called the PROMISE study. And what it did is it looked at women with DCIS, which is stage 0 breast cancer, so non-invasive breast cancer. And they gave them a few weeks of Duaviv, and then they rebiopsied them and they looked at a marker. It was a protein marker called Ki67, and they looked at this marker to see, has it reduced your risk of your breast cancer developing into an invasive cancer or reduced risk of recurrence? And they had really positive results, and they all had lowering Ki67. So it was really encouraging. So what Duaviv is conjugated estrogen, oral estrogen, and it is something called bazodoxifene. And what bazodoxifene is, it's a serum, it's like tamoxifen, and it seems to have more of a blockade to the womb and the breast, and seems to be protective to the womb and the breast. So I think watch this space with Juvie, because I think down the line this is going to be a really promising HRT.
Yes.
We don't have that in the UK. So in the UK, in practice, I will tend to use estrogen through the skin because any woman who's had a cancer is going to be at slightly higher risk of blood clots simply because of having cancer. So I think, okay, why take that risk? So I will give them estrogen through the skin, and there's no difference between patch, gel or spray. It's all just personal preference. You can kind of bung a patch on, forget about it, or some women love the routine of doing something every day with their gel or their spray. So they're all pretty much same, body identical, estrogen through the skin. And then if you have a womb, you need to have progesterone to protect the lining of the womb. And we much prefer to give a breast-friendly progesterone, so micronized progesterone. I think it's called Prometrium in Canada. Micronized progesterone, it is neutral to the breast, because we think actually the whole issue with HRT is not the estrogen. We know HRT does not cause a breast cancer. You have to have the abnormal breast cancer cell there, and we think that it's the estrogen that might make it grow. Whereas we think it's possibly this synthetic progesterone that can cause breast cell proliferation into abnormal cell, into a cancer. So it's not estrogen that causes breast cancer, but it might possibly be the synthetic long-term use of a synthetic progestogen. So we prefer to use a more so there is micronized progesterone, or there's didogesterone, and as I say, watch the space with Juvie because that looks really promising.
I was just going to say, it's so amazing to be on the forefront of this technology, and it's just very exciting. This is stuff that's happening in real time. There are going to be a lot of questions, and thank you so much for sharing this amazing information about all of this new stuff. So this is really great.
Because I see so many women who have been on HRT and get diagnosed with breast cancer in breast cancer clinic, and we know that if you are diagnosed with breast cancer whilst taking HRT, there is no increased risk of there's no worse outcomes. Outcomes are better, and risk of dying of your breast cancer and risk of all-cause mortality is lower. So women do better if they've been on HRT. So
fantastic.
We don't need to fear it, but we just have to be honest with women and say, look, we can't say it's 100% safe. We just don't know. If you've had breast cancer, we don't know. But it's all about sharing the risk, and it's the woman herself who's had the cancer that actually holds the risk when you give HRT. But it's having a sensible, holistic, joint decision making.
Yeah.
With hormone receptor positive breast cancer, they can come back even 10, 20, 30 years down the line, and it's a whole different ballgame if you're talking about a hormone receptor negative breast cancer, because if they're going to recur, they tend to recur in the first kind of 3 to 5 years. Once you're at your 5-year mark, you're probably pretty much home and dry. The concern with the kind of triple negatives is that if they do have a recurrence, the recurrence might be hormone receptor positive. And so again, with the triple negatives, I usually say to women, look, we much prefer to give you HRT, but if you're kind of between 3 to 5 years, once you're past that risk of recurrence of your triple negative. But there's, as I said before, it's all to do with how old you are, what your hormone status, and an example I often use when I'm teaching healthcare professionals or oncologists or surgeons is, say you have a woman who is in her mid-30s with a good prognosis, low-risk cancer, and you give her tamoxifen for 5 years. Well, you've not whipped out her ovaries. And if you give tamoxifen premenopausally, tamoxifen can actually increase estrogen, estradiol levels significantly. But tamoxifen is fabulous at blocking estrogen in the breasts, and that's how it works. But you've given it for 5 years, and after 5 years, she is now in her early 40s, and you've stopped the tamoxifen, and she goes back to normal periods. So then she gets to maybe 50, and she becomes menopausal and wants HRT, and everybody throws up their hands and horns and says, no, you can't have it. But that makes no sense. She's had her own hormones on board all this time, and she stopped her tamoxifen 8 years ago and has been having huge fluctuations in her own hormones. And so all we're doing with HRT is giving back a tiny, tiny wee amount. So it's just thinking of, not trying to go down the rabbit hole of thinking, oh, you've had breast cancer and nobody can ever have it, and just trying to have a logical conversation about it.
Yeah. I can understand how, if it was me, and you've been through this whole process of breast cancer, it's pretty scary to put yourself in a place where, okay, I'm going to take this HRT and what if, but I love that you do the consultation and that it's specific to each patient, specific to each cancer, obviously. And the people listening here are going to go, oh my gosh, how can I get hold of Dr. MacBeth? I need her in my life. And you're sitting in Canada or the US. How would you recommend, or what would you recommend for people who are listening to get advice, and where to get it, and how to ask their doctors for help with this?
So in North America, you can go onto it's not called the North American Menopause Society anymore, it's called the Menopause Society, but they have a list of providers. Now, you're not guaranteed that you're going to get somebody who will prescribe HRT after breast cancer, but you're going to get a properly trained menopause provider. The problem is that most oncologists are not menopause trained. Most gynecologists are not actually menopause trained. You would think they would be, but they're not. It's not part of their training, especially after the WHI trials. So many OBGYN programs don't include menopause in their training. Most family physicians are not cancer trained, and so women are in this void. But a good place to start is the Menopause Society preferred providers. If you're in the UK, British Menopause Society, we've got the same list of accredited specialists. And there's various podcasts that I recommend my patients to follow. So I love Dr. Eleanor Toplinski, Dr. Leila Agrawal, Dr. Corinne Menn. Dr. Corinne Menn's an OBGYN with breast cancer. Dr. Agrawal and Dr. Eleanor Toplinski are American breast oncologists. So they've got fabulous resources. The other thing I will just show you, there is our Menopause and Cancer charity. I don't know if you can see this. This is
yes, we can.
On Amazon. And so Menopause and Cancer is a charity that was started by Danny Binnington, who was a breast cancer survivor. It started a few years ago, and it's now basically international. We have basically podcasts every single week on anything and everything. So on diet, exercise, HRT after cancer, weight, supplements, anything you want, there is a podcast on every single symptom you can have.
Tremendous.
And then she's done a book, and there's a Facebook group. So there's a lot out there. In the UK, we've got charities such as Breast Cancer Now or Maggie's, and in the States, I think it's breastcancer.org, isn't it? And I can't remember the Canadian one. I should.
It's okay. Do you know what I'm going to do, Doctor? I'm going to drop everything that you've mentioned, the podcast, all the links. They will be in the show notes for audio. They'll be in the description for YouTube. The book, for the people that are listening to the audio, not seeing this YouTube, it is called Navigating Menopause After Cancer. So you can get that on Amazon. That is a great resource. So beyond HRT, I have people talking to me on the podcast saying, Andrea, I struggle. I have such terrible mood swings and low libido. My life is awful. I hate it. Vaginal dryness. What could you recommend if they're not in the process, they're not using HRT? Do you have any solutions for us today?
My absolute passion is what we call genital urinary syndrome of menopause. So in the old days, we used to call that atrophic vaginitis, which essentially means dried out old lady vagina. So we don't call it that anymore, because it's so much more than vaginal dryness. It's drying and thinning of the labia. It is drying and thinning of the vaginal tissues, and they can become so painful that women can't be intimate with their partners, or if they wipe themselves with toilet paper, they bleed. But it's lack of estrogen in the urethra that goes from the vagina into the bladder, and lack of estrogen in the neck of the bladder. So they get all sorts of needing to wee all the time, urgency, up all night weeing. I don't know if you know, I have breast cancer myself. I was diagnosed last year, and
No.
that was
Wow.
one of the biggest symptoms for me when I started letrozole. It was the bladder symptoms. I was literally peeing every 5 minutes, and
Wow.
it was miserable. And you know, women stop their endocrine treatments because of joint pains and GSM for the most part. So it's really important that we tackle these. And so I am a huge fan of vaginal estrogen after breast cancer. And actually, the American guidelines and the Canadian guidelines, they are fabulous and really holistic. Our UK guidelines, one of the guidelines isn't quite so holistic, although there's others that are better. But, you know, they all say, look, if you've had a previous breast cancer, you can have vaginal estrogen. If you've had a hormone negative breast cancer, you can have vaginal estrogen. If you've had a hormone positive breast cancer and you're on tamoxifen, you can have vaginal estrogen. The concern is if you're on aromatase inhibitor, but we now know actually using low dose, there's no what we call systemic absorption into the blood, and if we don't use these, then the woman's quality of life is significantly affected. You can get urine infections, you can get urosepsis, you put on weight because you can't exercise, your relationship breaks down. This is something I see every single day. I see women that have been admitted with sepsis, you know, at least once a week. It should never happen. And then what happens if you've got an older woman who is up all night weeing? Well, you know, she can fall and break a hip. And your mortality rate of breaking a hip is up to 30% in your first year. So I think it's really important that we get away from purely focusing on risks of breast cancer and think far more holistically about quality of life, you know, ability to exercise. So that's vaginal estrogen. Really important to use a vaginal moisturizer, pH balanced, and vaginal lubricants for intimacy. Pelvic floor exercises, get the blood flow into the pelvis, and women's health pelvic floor physio are worth the weight in gold. And then looking at non-hormonal treatments, you have slightly different ones than we do of the UK, but actually the ones that I stick with is escitalopram that you have in Canada, and I will go low dose, 5 to 10 milligrams, or I'll use venlafaxine, long acting, 37.5 to 75. And it's really important to say to the women, look, we're not prescribing this because we're thinking you're depressed. We're not saying you're depressed, go away, have this. We're saying, look, these are menopause doses, not anxiety, depression doses, and they help with the flushes and anxiety and joint pains. And those two don't interact with tamoxifen, because a lot of antidepressants will interact with tamoxifen. So if you stick with those two, you're the safest. You can use oxybutynin, which is actually an old-fashioned bladder medication, but if you take one at night, that works really well for the flushes and bladder symptoms. And you can use, sometimes I'll use gabapentin as well, which again is Neurontin in Canada, and just a wee tiny low dose at night is great for the kind of the flushes. All these do have side effects. So the side effects of gabapentin or the antidepressants, they can lead to weight gain and fluid retention and lower libido. And that's often what the women are really struggling with. So, you know, sometimes it can be a really hard sell. And then we've got the new kids on the block, which is your neurokinin 3 inhibitors. So fezolinetant, Veoza. Veoza's been out for longer in North America than it has in the UK, but that works in the thermostat in the brain and it turns that off, and so it works really quickly to help with the flushes and the sweats. It's a game changer. And anecdotally, it helps with sleep. And it is currently being tested in women who have breast cancer in the Highlight 1 trials. And then finally there's elazinitant, which I'm really excited about, and that has actually just been licensed in the UK and should hopefully be licensed in North America very shortly. And that has been tested in women with breast cancer in the Oasis 4 trials, and that works on the flushes and the sleep. And you know what, if you can fix your flushes, if you can feel better, if you're not waking up all night flushing, and then you have, because if you are, then it leads to brain fog the next day and exhaustion, and then your cortisol level goes up if you're not sleeping, and that puts your blood pressure up and your cholesterol up, and is an independent risk for heart disease. But if we can get you to sleep better, then you'll feel better the next day. Then you can do those positive lifestyle changes that make such a difference. Because what I say to every woman is, look, your first line treatment for menopause, if you've had breast cancer or any cancer or not, is going to be healthy diet and lifestyle. So your Mediterranean diet is the one with the best evidence. Exercise, including weight bearing and your strength and conditioning and your pelvic floor and your core. Don't need to tell you that.
The list goes on, doctor. The list goes on. But we know this, and you're right. Positivity is key. We know this, and we have the research and the evidence is there. So first line treatment, I 100% agree with you there. That's so, so true. I think finally for women who've been suffering for years, she was told she can never take HRT. Doctor, what is the single most important message you want to give her right now? What does she want to hear? What does she need to hear?
So I say never. And we are not in the 60s. We don't practice paternalistically. So you want to find somebody who can have a holistic, sensible, evidence-based conversation with you. Yeah. And if you get told no, then you go and find someone else.
Yeah.
And you arm yourself with all the evidence. So if you, again, on the Menopause and Cancer charity podcast, there's a whole series on HRT after breast cancer with all the links. So you basically download the links, take it with you to your healthcare professional appointment, arm yourself with the research.
You have brilliant information on your website. I was going through that, and they're lovely little booklets and information. Just quickly tell us a bit about that. I think that is going to be wonderful for people to get hold of and go through.
Yeah, and actually anyone can access those. And I was actually on holiday in Nova Scotia just a few months ago, and I was speaking to a woman in the Airbnb we were staying at, and she was asking me all about menopause, and I was like, you know what, just go onto our website. All the booklets are there. So we've got one on perimenopause, menopause, on all the symptoms, so weight, flushes, anxiety, low libido, genital urinary syndrome of menopause, and we've got all the up-to-date evidence and the treatments. We've got one in diet, supplements, histamine intolerance, and then we've got ones that just discuss all the different types of HRT, systemic and vaginal available. So there's a whole load of stuff on our website that anyone can download, and again, take it to your family physician wherever you are, because it's the same evidence.
Yeah, and I think we need to be armed. Quickly tell us your website.
It's Health in Menopause, so www.healthinmenopause.co.uk.
Fantastic. Dr. MacBeth, thank you so much for your time and for this very, very important conversation. You not only provided so much clarity on a topic that's shrouded in fear and so much misinformation, but you've also given women the language to advocate for themselves and their health. Your work is truly changing lives, and for that we are so grateful.
Thanks for having me on.
To all of our listeners, thank you for tuning in. We hope this conversation has really empowered you with the knowledge to make informed decisions about your health journey. Please comment in the YouTube comments and on the Spotify comments as well. Please ask your burning questions. I will bring the people to the podcast. Thank you so much, Dr. MacBeth. You are awesome. We think you are amazing.
Thank you so much.